beautiful symposium. I'm going to be talking about acute respiratory distress syndrome, and we'll discuss a little bit about the new guidelines or the changes in the guidelines. Beautiful symposium. I'm going to be talking about acute respiratory distress syndrome, and we'll discuss a little bit about the new guidelines or the changes in the guidelines. Covering every day something new about it. And the reason why, because ARDS is very heterogeneous. It has a diverse pathological causes, it has different clinical presentation. Every patient is different. And even the same patient, he can behave differently every day. And even the way they respond to treatment. So the patients are very, very unique, and you have to be smart with treating them. And the other problem is that we still don't have a magic pill for ARDS. The management is supportive. And what we mean by supportive is putting it on the ventilator. Now, if you're not smart with how to deal with these patients, you can actually cause harm than benefit. So that's the main problem, and that's why the mortality is still high. So we have a lot of challenges, both for the clinicians and the researchers. So how did it start? This doctor, David Oshbeck, and his colleagues in the 1960s, they discovered ARDS. It was during the Vietnamese War. So they found a lot of patients who were suddenly developing acute onset of hypoxemic respiratory failure. They had pulmonary edema. They had very, very low compliance and stiff lungs, and their heart was absolutely fine. So they said, this is not a cardiogenic pulmonary edema, definitely it's non-cardiogenic pulmonary edema. The incidence of ARDS, interestingly, it's age dependent and it's sex dependent. So it's more commonly in elderly, from 16 per 100,000 in the young patients to 306 per 100,000 in the elderlies. And they noticed that it happens more in men than female, but the mortality in both groups are the same. So it affects around 3 million people globally every year. So you can understand the huge impact of ARDS. The mortality, despite all these years in research and advance in treatment, it's still high. Yeah, it's still, in severe case of ARDS, it can go up to 45%. The cause of death is mainly due to sepsis and multi-organ failure. And interestingly, even the ARDS survivors who managed to go home, they discovered that 20% of them die after 1 year, and they're mainly young patients. So this is a huge study. It was done in 2014. It's called the Lung Safe, published in JAMA. And it stands for Large Observation to understand the global impact of severe acute respiratory failure. And what they concluded with that, despite all these years, as we said, the prevalence of ARDS in ICU is still high. Around 10% of ICU admissions are ARDS. And we still don't recognize these patients early and treat them early, and that's why the mortality is still high. And despite the lung protective strategy, which became very, very famous, and we assume that everyone is practicing it, they found that still less than 2/3 of these patients actually received low tidal volume. And I think the reason why is that it's not because of negligence of the doctors, it's because they actually realize that every patient is unique, and not all of them really did require this low tidal volume. So this is the timeline of ARDS. So you can see so many researches, so many changes every year or every month. There is something new coming up. So it started at the beginning. They thought it was just pulmonary edema and atelectasis. But the actual name of ARDS was discovered in the around 1970s. Initially it was called adult respiratory distress syndrome, but then they discovered that it also happens in pediatric. So it was changed to acute respiratory distress syndrome. And they also discovered the benefit of PEEP, the benefit of corticosteroid, and then protective lung strategy, because they noticed that mechanical ventilation can cause so many types of injuries, as Dr. Saif has mentioned. And then they came with the definition of ARDS. So the Berlin definition, 2012, was very, very famous, and then later on it changed, and we're going to talk about that. So initially we thought that all IDS patients have to be intubated and put in a mechanical ventilator. But during the COVID era, things started to change. We discovered so many things, so many new things started to be practiced. And one of these things was conventional oxygen therapy or non-invasive respiratory therapy. So you can put the patients on high flow, non-invasive, CPAP, in order to avoid all the problems that happens with the ventilator. But you have to be very, very cautious, especially in high-risk patients, like immunocompromised or multiple comorbidities. They can deteriorate very, very fast. And they actually noticed that if you delay intubation in these cases, that can increase the risk of mortality. But high flow itself started to gain a lot of popularity. It washes the dead space. It's more comfortable for the patient, but you need to be cautious. So it can cause delay intubation. You can't control the tidal volume and the PEEP with that, so that's why you have to keep an eye on them. And some of them, they don't have a proper seal. You cannot say how much PEEP. And the high flow, for example, if you ask the patient to close his mouth, he can keep a considerable amount of PEEP, but he can't measure it. You don't know how much exactly they have. And that can cause, of course, de-recruitment and atelectasis trauma and all these things. So there are some things that we can use, like, for example, the ROX index, the Hacker score. And I'm not going to talk about that because we're talking about invasive in this symposium mainly. So that's why even the definition has changed a lot over time. As we said, initially it was not very specific, so that's why we were also confused. We didn't know who to put under the category of ARDS, but then the Berlin definition made it a little bit more clear. So they said that the onset should be within a week of the insult. You have to have bilateral consolidation on the chest X-ray, and you have to have a minimum of 5 PEEP. Okay, and then they classified it to mild and moderate and severe. So mild, using, of course, the PF ratio, which is the PaO2 over the FiO2. If it's 200 to 300, it's mild. If it's 100 to 199, it's moderate. And if it's less than 100, it's severe. Now, after that, they noticed that in the low resource setting countries, like, for example, Africa, the places which they don't even have an ABG, they don't have an X-ray. So they said, okay, what are we going to do? We have to look for something else. So instead of measuring the PF ratio, they measured the saturation over the FiO2 ratio. So the SF ratio became more common, and this was actually in 2015 in a place called Kigali in Rwanda. They came out with this modification. So using the saturation FiO2 ratio, using the lung ultrasound, now ultrasound became very, very common. We discovered that it can be used over worldwide because it's easier, it shows you real-time diagnosis, and it can help you with so many things which we're going to discuss later on. So that was the change in the definition. And of course, they included also the patients who were not intubated, who were not on the mechanical ventilation, like the high flow and non-invasive. So the cause of ARDS, as we all know, there is direct and indirect. So direct is in the lung, pneumonia, bacterial, viral, fungal, aspiration pneumonia, and that's the commonest direct. The commonest indirect is severe sepsis. And we also have risk factors like smoking, chronic alcohol, any underlying lung disease, of course. They're not going to be able to tolerate this injury. And also we have transfusion. TRALI is one of the causes, especially platelets. And e-cigarettes, which now is called as e-valley, vaping-produced use of associated lung injury. So why is ARDS tricky? Because their lung is very heterogeneous, as we said. Now there are areas at the top, they're normal, okay, but it's very small. And that's why you call that the baby lung. So we are just ventilating or oxygenating this area. That's why we don't need to use a very high tidal volume. And then we have the atelectatic in the middle and collapsed at the bottom. And this actually, this picture, which was studied in animals, it shows you that not only ARDS can cause this, like hemorrhage, as you can see, flooding, alveolar flooding, it's also from the mechanical ventilator. Unfortunately, sometimes we cannot see that. We cannot pick it up early. So what actually happens in ARDS? As you can see in this famous diagram, it shows you the difference between the normal and the ARDS alveoli. So basically in ARDS, after the injury, whether it's direct or indirect, that will stimulate the macrophages to release tons of cytokines. It's a cytokine storm, similar to sepsis. So you have interleukin, you have TNF, okay? So we have lower inflection point and upper inflection point. Now what happens here, when the ventilator gives a breath, the pressure will start to build up at the beginning because the alveoli is not going to open immediately. It's going to take some time till the pressure builds up. And when the pressure builds up, then suddenly you're going to have high volume. Now, this is the safe zone. This is where we tend to keep the volume and the pressure. So we always monitor this on the ventilator. We don't want it down there. So anything below the lower inflection point will cause atelective trauma. Anything above will cause volutrauma. So it's a double-edged sword. Mechanical ventilation can be useful and can actually harm the patient. So this is what we know. Minimizing ventilator-induced lung injury is the only effective thing that we have in ARDS till now. So rule number 1, never make it worse. And rule number 2, don't forget rule number 1. And basically, this is what we know. What we still know till now, despite 70 years, is just the tip of the iceberg. There is still a lot to be discovered, especially now with the AI and all these things. I'm sure we're going to have a lot of changes soon. And that's why this ayah came across my mind. وَمَا أُوتِيتُم مِّنَ الْعِلْمِ إِلَّا قَلِيلًا. And you were given only a little knowledge. That's very, very true. So our goals initially, we were trying to focus on keeping the oxygen normal, okay? But we didn't know that the ventilator can cause harm. Then later on, when we saw all these problems, barotrauma, volutrauma, we said, okay, now we have to be cautious. We have to bring the tidal volume down, monitor the pressure. Okay, initially it was the peak, then we looked at the plateau, and then we said, okay, we have to have a minimum of PEEP so we can keep the alveoli open, and then came up the driving pressure, Dr. Saif mentioned, and then the last thing now is the ergotrauma, which is related to mechanical power, and we're going to talk about that. So this is a famous trial published in New England Journal in 2000. This was the landmark trial. This changed the practice. So before, they used to give huge tidal volume, like 18, 20 ml per kilo. But when they compared that to 6 ml per kilo, of course, per ideal body weight, they noticed that the mortality significantly decreased from 39 to 31%. Now, the problem with this is that, as I mentioned earlier, why the clinicians were not using, or they're not strictly adherent to this strategy, because they noticed that it's not about the tidal volume, it's about the compliance. So sometimes even when you give patients who have very, very low compliance this tidal volume, it can still be harmful. And the other thing which is not so clear, okay, you compared it to 6, but what about 7 ml or 8 ml or 9 ml? Can we use something in between, or do we have to be strictly using 6 ml per kilo? So the two cornerstones of managing ARDS was initially low tidal volume and PEEP, okay? And as we mentioned, the reason why, because it increases the FRC, it keeps your alveoli open, it avoids de-recruitment and injury, and it actually even moves the fluid from the alveoli back to the interstitial space. And then in 2013, PROCEIVA trial came, which showed you the benefits of proning, okay? But that was especially in severe cases. So we don't prone the patients immediately. We try the initial measures, and then if that failed, Then we use prone, and the minimum session was around 16 hours. We still don't know how many sessions should they receive. Like sometimes they improve from the first session. Okay, what shall we do now? Shall we continue or shall we just stop? But this was a landmark trial also, which showed a huge reduction in mortality from 32 to 16%. And the reason why is that in supine position, as you can see here, the heart from above and the liver from below, they're actually compressing the lungs, which are already fragile, okay? So when you put them prone, you're basically offloading the heart and the liver, and you're even, with the gravity, it will mobilize the fluid and it will significantly increase the oxygenation, the compliance, and all these things. And you will have a more homogeneous distribution, and even the shape of the alveoli will change. So in this experiment, they compared the supine to the prone, as you can see. In the supine, the dorsal alveoli are all collapsed. But in the prone, especially over time, they start to open up and they will be all homogeneous in size, which improves the distribution of ventilation. Now, another type of injury was even discovered, which is called patient self-inflicted lung injury, or PSILI. This was noticed more during the COVID era. So basically, when the patients are in severe distress, they're in air hunger, they're trying to get as much as air or oxygen inside, and they create a very negative intrapleural pressure. So you can see here, the intrapleural pressure will go up to -20. And that will cause uneven or heterogeneous distribution of the stress and strain that will increase the injury, and they notice that they have a higher incidence of mortality. And that's one of the things of this synchrony which Dr. Saif mentioned. This synchrony increases the mortality. And you have to pick these patients early and try to manage them as soon as possible. So one of the management is either changing the mode, pressure support, for example, minor adjustments like flow rate, the inspiratory pause, looking for auto PEEP also, increasing the tidal volume, increasing sedation also can help. So why is it important to measure the patient's effort? Because you have to keep a balance. You don't want them having a too high effort, which is causing PSILI. Even it can cause ventilator-induced diaphragm dysfunction that can prolong the weaning. It can increase your oxygen consumption, it can cause more discomfort and agitation, and at the same time, you don't want them knocked out. You don't want the efforts too low, where that can cause diaphragmatic atrophy and weaning failure. So the ARDS NET, this was a team which came up. They said, okay, let's standardize the protocol to make things easier. That was at the beginning. In 1994, they published this famous, it's like a manual. So it tells you exactly what to do, step by step. So basically, they're focusing on three things: the tidal volume, the PEEP, and the plateau pressure. I'm not going to talk too much about that. But the problem with that is that you're as if you're treating these patients as a robot. And they discovered that one size doesn't fit all, as we have mentioned. Now, this famous Dr. Gattinoni, they considered him the father of ARDS. Unfortunately, he died last year. He had so many researchers, and especially during COVID, he noticed that not all COVID ARDS were the same. So he categorized them to type L and type H, and we're going to talk about that. But that was the introduction of personalized medicine. So personalized medicine is not something new, it has been there, but we didn't know how to apply it. So it's the concept that treating every patient as a unique patient, they have different susceptibility, they have different response to the treatment. And actually Hippocrates, more than 2,000 years ago, he stated that it's far more important to know what person the disease has than what disease the person has. So that's why later on they starting sub-phenotyping the patients or categorizing ARDS, because they noticed that not all of them, they act the same. So they said, okay, let's categorize them either according to the physiology, biology, morphology, and so on. So the first one was biological heterogeneity. Biological heterogeneity meant that These patients, they were either hyperinflammatory and hypoinflammatory. So this was similar to the COVID, the one that Gattinoni mentioned. So they both have inflammation, but the hyperinflammatory type, they had really aggressive inflammation. They had really high concentration of biomarkers. They were sicker, they were more acidotic, more hypotensive, they had a high prevalence of sepsis, and of course they had very, very poor oxygenation. And these subgroup actually benefited more from PEEP than the hypoinflammatory. And these are the two main mediators which were released. They discovered something called RAGE, receptors for advanced glycation of end product. This was a marker for alveolar inflammation, whereas the angiopoietin was a marker of vascular inflammation. And that was very, very interesting. So if you know which patient, which marker your patient has, then you can treat accordingly. And they also noticed that the hyperinflammatory, of course, they had higher mortality, as we said. They're less common than the hypoinflammatory, only 1/3 of the patients, and they had a lower level of protein C. And that was actually looked at in the previous trials. Initially, it didn't show any mortality benefit because they were looking at all the patients as a whole. They didn't categorize them. But then, when they studied it on the hyperinflammatory subgroup, it actually did show benefit. Also, as we said, the PEEP. So the high PEEP only benefited the hyperinflammatory. Simvastatin. Also, simvastatin initially, it was not really rewarded, but then they noticed that, no, actually the patients who benefit is the hyperinflammatory group. And also the fluid. So the fluid liberal, we used to say, try to minimize fluid as much as you can because you don't want to aggravate the pulmonary edema. But in the hyperinflammatory, actually, their fluid requirements were higher and they did benefit from a fluid liberal strategy. And then we have the physiological heterogeneity. So the physiological, maybe it means that there are recruitable groups and non-recruitable. So the recruitable, they have more non-inflated tissue, they have lower compliance, they have lower PF ratio, higher mortality, and they benefit more from the higher PEEP. Also etiological. So we have, as we said, pulmonary and extrapulmonary cause, right? So the pulmonary, they had a higher compliance, they had focal pattern, it wasn't a diffuse classic ARDS, and they did actually better, especially they responded more to prone. Whereas in the extrapulmonary, they had lower compliance, a high pleural pressure, it was more diffuse, and they had higher biomarkers and higher mortality. Temporal heterogeneity, which is early versus late. Now we all know that in the early stage, there's exudative stage, and these patients respond to certain maneuvers, so that's why it's important to pick them early. So it's more with hemorrhagic shock and trauma patient, it responds to protective mechanical ventilation, they have even elevated high biomarkers. But the late, of course, they're not going to respond that much to the similar strategies, and they have a higher mortality. The last one is the morphological. So as we said, we have focal and diffuse. The focal respond more to the prone, and the diffuse respond to alveolar recruitment. What we mean by alveolar recruitment is that it's like a rescue strategy. So some patients, when they are very, very hypoxic, they're not responding to whatever you're doing. We just give them a brief high pressure, so we can go up to 40 or 35 for around 35 to 60 seconds. But you have to be cautious, of course, because that can cause hypotension and barotrauma. Now, these were the changes in the guidelines. They are still agreeing on low tidal volume. Low tidal volume is really, really important, okay? And of course, high PEEP is beneficial, but we still don't know how high should we use. Now, there are two tables, for example. In the ARDSNet, they have the high PEEP, low FiO2, and the low PEEP, high FiO2, but we still don't know. It has to be personalized, and Dr. Anis is going to mention that in the next presentation. They recommended against prolonged recruitment maneuvers. So don't use it for a very long time, because it can be harmful. Proning was strongly recommended for moderate to severe ARDS. The earlier, the better. Don't wait till the patient is already in the fibrotic stage. They're not going to respond. And it has to be in the severe ARDS. Of course, high flow nasal non-invasive is also encouraged. as an initial strategy to avoid intubation and all these problems. And also paralysis. Paralysis and severe ARDS is recommended. And they actually noticed that it reduces the mortality. One of the studies which was published, the ROSE trial, it showed that it significantly reduced the mortality. And the reason why is because basically you're going to have less dysynchrony. And of course, all the problems with dysynchrony is going to be eliminated. And they have better improved compliance, so less collapse, less de-recruitment, and it also has a direct anti-inflammatory effect. But you have to be also cautious and not keeping them on a long time because, of course, all the complications with sedation and paralysis. And also the steroids, it came back again. So during the COVID, it was highly encouraged for most of the patients, but in the early stage. Now, the last thing I'm going to talk about is personalized mechanical ventilation. So even mechanical ventilation now is becoming more and more smart. So we used to look first at the plateau pressure, but then they found that it's not really indicative because it's a static measure. Anything which is static doesn't give you an idea about the patient as a whole or what's going on. So that's why they said, okay, let's look at the driving pressure, which is the difference between the plateau and the PEEP. And they did notice at the beginning that the mortality did reduce. The cutoff was 15, so anything less than 15, they had lower mortality. And they noticed that especially with the elderly. So the elderly patients were very, very sensitive to high driving pressures. But then later on, they found that there's another measure that we can use, and it's more sensitive than the plateau and the driving pressure, which is the mechanical power. Now, this is a little bit complicated. I'm not going to go into so much details, but just a quick word about it. So basically, it's the amount of energy per unit of time which is transmitted to the respiratory system by the ventilator. And this looks at the patient as a whole. So you're not only looking at the plateau or the driving pressure. No, you're measuring so many things, including the tidal volume, pressures, of course, flow, and the respiratory rate. Now, interestingly, they discovered the respiratory rate actually can cause more harm. Because as we said, every movement of the alveoli can cause injury and stress. So it might be a better driver for lung protective ventilation than individual parameters, as we said. And this study was retrospectively done in 8,000 patients. They noticed that the cutoff here was a mechanical power of 17 joules. So anything more than 17 will increase the mortality, but a little bit complex. There's a complex formula for it, but we're trying to measure or look at the driving pressure with the respiratory rate in order to avoid injury. Personalized mechanical ventilation by the ultrasound. So ultrasound, as we said now, it's very, very helpful, not only in diagnosing, also in phenotyping, monitoring, and looking for complications and personalizing the PEEP. And we have something also which is called the electrical impedance tomography. It's like a strap which is put around the chest, and it basically gives you an idea about the aerated lungs. So you can see here, the aerated lungs they have a different color. So what you can do is you can personalize your PEEP according to that. So you keep on increasing the PEEP till you get a good image, and then you say, okay, this is the PEEP for my patient. So what's the future of ARDS? We talked about supportive therapy. We talked about personalized therapy. There's also cell therapy, which is stem cell therapy. There's lots of research about that. And there's also targeted therapy. So each biomarker, they want to inhibit it. And there are lots of researches which hopefully will come out in the light. And also one thing which looks promising is the closed loop mechanical ventilator. So you're gonna have a smart ventilator. Instead of keeping an eye on the patient, keeping an eye on the parameters, the ventilator will do everything for you. So this is an example of one of the ventilators, Hamilton Intellivent, which basically you enter the targets that you want, the oxygen, the CO2, the FiO2, and you enter the patient's data, and the ventilator will do the rest for you. And also helps in weaning, so it has a quick weaning mode, and it can help you with the weaning. So in summary, what they recommended was the strong recommendation, as we said, low tidal volume, prone positioning early, and the conditional recommendation was the PEEP, corticosteroids, ECMO, paralysis, and the strong recommendation against was the prone recruitment maneuver and the high frequency oscillation. Thank you. Beautiful symposium. I'm going to be talking about acute respiratory distress syndrome, and we'll discuss a little bit about the new guidelines or the changes in the guidelines.